Hi, good afternoon. I'd like to thank Sue Friedman and the coordinators of the FORCE meeting for inviting me to speak to you today about breast implants. My name is Liza Wu, and I'm a pen plastic surgeon, and I'd like to tell you all about what you should know about breast implant reconstruction. My only disclosure is that I'm the principal investigator for the Mentor Athena trial. Typically, when you talk about implant-based reconstruction, it is done in two stages. The first stage is when the mastectomy is performed by the breast surgeon, and a plastic surgeon comes in and places a tissue expander into the pocket of your breast. When you wake up, you're essentially flat. Then you undergo a series of expansions, typically on a weekly basis, to stretch the overlying tissues. Once the stretching is completed, you go back to the operating room to remove the tissue expander, and this is replaced with your implant. There are certain advantages and disadvantages to this two-stage expander implant reconstruction. Advantages include that it allows the tissues to recover after the mastectomy, it allows the patient to control the expansion process, and it also allows the patient to choose the size. Disadvantages is that the expansion process takes time. It also has two separate surgeries to achieve the outcome. Again, with two-stage expander implant reconstruction, the first stage is the placement of a tissue expander, typically underneath the muscles of your chest. Stage 2, in the second surgery, is the exchange of the tissue expander for a permanent implant. Here is a schematic of where the tissue expander is typically placed on the chest. It is below the skin, below the muscle, on top of the chest wall. This is an example of a two-stage expander implant reconstruction. On the left side of your screen is the patient preoperative. In the middle of the screen is the patient with tissue expanders in place, and at the right side of the screen is after implant exchange and nipple reconstruction and tattooing. This is another example, again pre-op on the left, tissue expanders in the middle, and implant-based reconstruction with nipple and areola tattooing. This is a woman who underwent unilateral mastectomy, so one-sided mastectomy. The middle photo is her with her tissue expander on the right breast. And then on the left is the exchange of the right breast for an implant and a left breast reduction to achieve symmetry. Some women are candidates for one-stage direct-to-implant reconstruction. What this means is that at the time of the mastectomy, the plastic surgeon can come in and place a full-size implant at the time of the mastectomy without having to place a tissue expander and undergo the expansion process. The advantages of this type of surgery is that it's one stage, so no expansion, no exchange surgery. The disadvantage is that it cannot be performed in mastectomy skin flaps that are very thin or compromised. Patients who wish to go larger cannot have this type of reconstruction, and you cannot do it in patients who smoke or patients who have had previous radiation. This is an example of a patient who underwent bilateral mastectomies and direct-to-implant reconstruction, nipple sparing. Another example of a patient who underwent bilateral mastectomies and direct-to-implant reconstruction. And then finally, a patient who underwent bilateral mastectomies and direct-to-implant reconstruction. All these patients did not have a tissue expander placed and did not have to undergo the expansion process to achieve their implant-based reconstruction. Next, I'd like to talk about what you and your plastic surgeon should decide when discussing implant-based breast reconstruction. We're going to talk about implant fill, whether it's silicone or saline, implant surface, smooth versus textured, implant shape, round versus teardrop, implant size with regards to volume, projection, and diameter, and implant position, whether it goes behind the muscle or in front of the muscle. Your implant can either be filled with silicone or saline. Silicone implants are filled with a silicone polymer, and your saline implant is filled with salt water. The shell of either implant is a silicone shell. Silicone implants tend to feel and look a little bit more natural. Saline implants are a little bit more firm. Silicone implants have less rippling than saline implants. The difference between the two mostly comes when the implant ruptures. When a saline implant ruptures, your body absorbs the salt water. When a silicone implant ruptures, your body does not absorb the silicone. The silicone typically stays within the capsule of the breast implant. Next, we'll talk about implant surface. The surface of your implant can either be smooth versus textured. Textured implants are typically thicker and rougher than smooth shelled implants. A smooth implant tends to move within the pocket. A textured implant was created so that it would not move within the pocket and stay in place. Textured implants have found to be associated with something called anaplastic large cell lymphoma. Breast implant-associated anaplastic large cell lymphoma is a lymphoma that is associated with breast implants. It was first identified approximately 10 years ago. The cancer is found within the capsule around the implant. It is not your typical breast cancer. It is more of a lymphoma. It can present as a swelling or a mass. It is likely associated with textured implants. Your risk of developing anaplastic large cell lymphoma is approximately 1 in 1,000 to 1 in 30,000 in patients with a textured implant, depending on the manufacturer. In comparison, your risk of developing breast cancer for somebody who is not genetically predisposed is approximately 1 in 8. Anaplastic large cell lymphoma can be treated. It's treated with surgery to remove the affected implants and capsule, and potentially with chemotherapy as well. Next, we'll talk about implant shape. Your implant can either be round or shaped. A round implant is completely symmetric in all degrees. A shaped implant is teardrop shaped, in which the superior pole of the implant is thin and the inferior pole of the implant is more projecting. This is what an anatomic versus round implant looks like when it's in the body. With an anatomic implant, you have a less full upper pole and a more full lower pole, giving you that teardrop shape that I had mentioned. With a round implant, you have more upper pole fullness and more of a symmetric breast shape. In order to keep this implant in place, they have to put that texturing on the shell. And as I had mentioned, the texturing is the one that's associated with the anaplastic large cell lymphoma. When your plastic surgeon talks to you about implant-based reconstruction, one of the biggest factors that come into the evaluation is volume. When we talk about volume, it essentially is the size of the breast that you want at the end of your reconstruction. Breast implants come in many, many, many different sizes, but they are all pre-filled. So your breast volume can be anywhere between 100 to 800 cc's typically. Another aspect of implant size is projection. As you know, women's breasts come in many different shapes and sizes. So the implants are made to reflect these different shapes and sizes. You can choose anywhere from low profile to extra high profile implants that give you different amounts of projection. And finally, we also consider implant size, or the diameter of the implant. Depending on how wide your chest wall is, your plastic surgeon will measure and choose an implant that fits your chest wall. Finally, I'd like to talk about implant position. As I mentioned earlier, the implant can go either underneath the muscles of your chest or on top of the muscles of your chest. Traditionally, implants were placed underneath the muscles of the chest because it was believed that this would protect the implant from something called capsular contracture, or hardening of the scar tissue around the implant. With the development of special material called acellular dermal matrix, we are now able to place the implant on top of the muscle if the surgeon leaves you a very healthy breast envelope. Whether the implant is on top of the muscle or below the muscle, there's advantages and disadvantages of either. Behind the muscle, there is more coverage overlying the implant. There's more protection, the implant is more secure. It is thought that there's less rates of infection and less rates of something called capsular contracture. On top of the muscle, however, there is no muscle dissection needed, so less postoperative pain. There's also something called no animation deformity. Animation deformity describes what happens when your skin scars down to the underlying muscle, and when you contract your muscle, your skin wrinkles on top of it. To be able to place the implant on top of the muscle, you have to use something called acellular dermal matrix. Acellular dermal matrix is skin that's taken from somebody who's passed away. It is processed, so there's no cells, so you can't get hepatitis or HIV like a transplant. What it is, it's like a scaffold, and then your own cells populate the tissue matrix, and it becomes part of your body. Using this material allows you to create your own pocket for the implant to lie. Next, I'd like to talk a little bit about complications. After the mastectomy, one of the biggest challenges that plastic surgeons face is something called mastectomy flap necrosis. Mastectomy flap necrosis happens when the breast gland is removed and the overlying breast skin is left thin and damaged and does not have good blood supply. When this happens, the overlying breast skin can die, causing necrosis. If this happens, it is very difficult to be able to maintain either an expander or implant in the pocket. This can be fixed by either removing the dead skin and placing either a smaller implant or maybe even a tissue expander into the pocket, letting things heal, and then continuing with the process subsequent to that. Another potential complication is seroma. After the patient has the mastectomy and the implants are placed, drains are placed to drain fluid that may collect into the pocket. If those drains are removed too early or are not doing their job, you can collect fluid into the pocket. This can either be drained with a needle through the skin, or the patient can be wrapped to encourage the body to reabsorb the fluid. Next is something called implant malposition. This woman underwent bilateral mastectomies and direct-to-implant reconstruction. As you can tell on the left side, her implant sits lower than the right side. What has happened is that the implant has slipped out of the pocket and fallen down lower than where it should be. This can be corrected by going in and surgically removing the implant, reestablishing the fold underneath the breast called the inframammary fold, and hiking up the implant, typically using the acellular dermal matrix. This is another example of implant malposition. The left breast implant in this patient is placed laterally or out towards her armpit. Again, this can be fixed. It would mean a return trip to the operating room in which the scar tissue is released and the implant is placed back into place and then reinforced either with sutures or acellular dermal matrix. After nipple-sparing mastectomy and implant-based reconstruction, you can have something called nipple malposition, where the nipple migrates to a different portion of the breast. On the patient on the left, you can see both nipple areolar complexes, although they're symmetric, have migrated laterally. On the patient on the right, you have a very nice bilateral implant-based reconstruction. However, the nipple on the left has migrated superiorly and laterally. This is a very difficult problem to overcome, and if it's that bothersome, some may even recommend removing the nipples and then having them tattooed into the correct position. This is an example of implant rupture. This woman has a saline-based implant reconstruction on the right-hand side. She reports that one day she woke up and that the implant appeared to be smaller and that the wrinkling was more pronounced. Implant rupture occurs 100% of the time. The rupture rate is 1% per year, and at 10 years, rupture rates go up to about 10 to 15% depending on the manufacturer. Subsequent to the 10 years, rates of rupture continue to increase. We tell our patients that implants will last, hopefully, approximately 10 to 15 years. If you have a silicone implant, you may not see a change in your implant. That's why it's very important to continue to follow with your plastic surgeon and potentially get imaging to show whether your implant is intact. This is an example of implant infection. This woman underwent bilateral mastectomies and implant placement. A few weeks later, she developed warmth, redness to the right breast. Unfortunately, this woman had to be admitted for IV antibiotics and went to the operating room for washout. We were unable to save this implant. And finally, this is an example of something called implant contracture. What happens here is that the scar tissue that forms around the implant becomes hard and heavy. This can deform the breast reconstruction and eventually may even cause pain. This is also a very difficult problem to overcome, but will require moving the implant, removing the scar tissue, and replacing it. Lastly, I'd like to touch upon something called breast implant illness. Breast implant illness, or BII, is a term that women use to refer to a range of symptoms that develop after undergoing reconstruction or augmentation with breast implants. It is used when describing a cluster of symptoms such as fatigue, rashes, joint or muscle pain, and memory or concentration problems. It can happen with any type of breast implant: silicone, saline, smooth, textured, round, or teardropped. BII, or breast implant illness, is actually not recognized as an official medical diagnosis, however, has been reported by thousands of women. When these implants are removed in these women, not all the symptoms may go away, pointing to the fact that breast implant illness may be caused by multiple factors. This concludes my presentation on what you need to know about breast implant reconstruction. I know I gave you a lot of information in a very short amount of time. Please do not hesitate to reach out either to your plastic surgeon or myself should you have any questions about what I've presented here, or questions about your own breast reconstruction journey. Thank you.